You're listening to Vaccine Curious. The coronavirus pandemic begs the question, what do we know about vaccines? This podcast investigates vaccines from an individual, a societal, and scientific perspective. Your host is Professor in Global Health from University of Southern Denmark, Christine Stabell Benn. Welcome to Vaccine Curious.
I'm so thrilled that you are finally here. Tracy, you're here on summer vacation.
Yes, that's right.
Leaving sunny California for Denmark. And finally, we are here face to face after several years of writing back and forth with each other. And actually also in the meantime, getting you affiliated with University of Southern Denmark, my university. So I'm really thrilled about that. And thrilled to have you here face to face. And what we've decided to do today is to make a pop-up version of my podcast, Vaccine Curious, in collaboration with your podcast, which is called
Sensible Medicine. That's right.
And invite people around the table here where we will have our first face-to-face conversation about what has happened during these last 2 years and much more, I guess. As much as we can do within the hour that we have set aside for this first talk.
And this is going to be an ongoing discussion. This will be the first of, I hope, many podcasts because, as I think listeners will hear, we have a lot to talk about. We've already been talking basically for 2 days straight, first in Danish, then in English. And we have no shortage of topics to discuss. And I'm glad that you brought up that we are now both you're a full professor of global health at University of Southern Denmark, and I'm now affiliated an adjunct associate professor there. And so one of the things I think we hope to achieve with these discussions is talks about collaboration between the United States and Denmark in terms of research and in particular research around into vaccines, vaccine safety, vaccine efficacy, how we can have better data moving forward. And so I think this will be a very exciting opportunity and collaboration. And we should probably let the listeners know we're first going to start by talking a bit about the COVID-19 pandemic. That's really how Christine and I got to know each other, and we'll talk about the COVID-19 vaccines. And then we're going to segue into talking about vaccines in general and how to do research into vaccine safety and look for rare safety signals and kind of discuss a lot of the things that have come up recently in the media, also with RFK Jr. And I guess we should discuss that neither of us have shied away from controversy, and so we'll probably get into some controversial topics. And I
interestingly,
guess,
when we just talked briefly before this actual podcast, we were talking about how I was asking you whether you had been touching upon controversial areas before COVID-19, and it turned out that you had in some situations been confronted with the situation that the things that you had, where you had seen the data and felt sure that you had one interpretation had been confronted with the fact that many other people would have a completely different interpretation. And I guess that's something we have in common. My research has also led me into questioning, previous to the COVID-19 pandemic, whether it was always right, was what was in the textbooks or what authorities said. So I guess that's a common denominator for us.
Yes, I should mention, then you can say what your research was in, but a lot of I guess my experience was looking into the research of exercise during pregnancy, and I was really a long distance runner during my first pregnancy, and I would run up to 16 miles a day, and I had basically it was an anonymous blog where I wrote about running and exercise during pregnancy, and I was very surprised how opposed people were to women exercising and running, and certainly that was a lot of miles to run when you're pregnant. But basically, how the public opinion had not caught up with the science in terms of the safety of exercise during pregnancy, and that the observational data had been pretty consistently showing benefits. And so in my mind, I kind of thought, well, if the data have been very reassuring, and if women want to exercise, they really should feel safe to do so. And that I guess having that experience made me comfortable with controversy and sort of writing online and about things that that the general public might not necessarily agree with immediately, but that if you follow the research closely, that you shouldn't be afraid to ask questions and so, question the dogma of the time. And so
that's so interesting because, I couldn't have expressed it better. My area was vitamin A supplementation and also vaccines after that and their interactions and sex differences and things that people really hadn't questioned or where there were several dogmas that I've been not out of some need to challenge dogmas. In fact, I think of myself as somebody who like to reach consensus with people, but again and again, my research has led me to question dogmas. And I guess the more you do it and you find out that the dogmas are not actually worth the paper they're written on sometimes, then you get comfortable with, that if you have the data, it's justified. It's actually necessary and important that you ask questions. So I think we had that in common when COVID hit, and when we both found ourselves in each our country questioning how authorities were handling this pandemic.
Vaccine curious.
Yeah, and I will say, having the experience of working as a physician in two countries also has made me constantly second guess myself, double check the literature and the science, and so that I can defend what it is I'm, recommending to patients, what it is that I'm saying, because Denmark and the US, they actually have a lot of differences. In terms of medical care, and I think that's a good segue to talking about the pandemic, because I had been in the United States 5 years when the pandemic hit, and I was still reading the Danish newspapers, still really felt on the inside like I was Danish.
Maybe we should just bring the Danish audience that may not know you on track here, because you did your PhD in Denmark. You have a Danish father, right?
So I don't have a Danish father. I have a Danish husband, actually. So yeah. But I did my PhD after. So I did my MD in the United States and my PhD in Denmark, and so lived in Denmark for 7 years before moving back to the United States and raised my kids here. And I think, that I had young kids when the COVID-19 pandemic hit. And so looking at the way Denmark was approaching children during the pandemic with regards to school reopening and masks and seeing how it diverged so much from what I was seeing in California, it really made me realize, well, of course there is no consensus here, but in my experience, Danes really place childhood, and they place a lot of value on childhood, and children are a focus, a large focus of the Danish society, and children's well-being gets more attention in Denmark than it does in the United States. And so immediately I could see that children were sort of experiencing mitigation that wasn't necessarily for their benefit, but in the hopes that it was going to protect an older population. And to me, that it was a fundamental problem that, children's needs weren't being considered as much as adult needs were. And so we were attempting to have this discussion about, how many doses, any doses, what's the appropriate strategy for vaccinating children for COVID-19. And then you come out with this paper asking, should it actually just be a disease of childhood based on what we know about the risks of COVID-19 to children? And I just wonder if you could start out by talking about that and sort of also your involvement in the pandemic.
Yeah, I guess I came with these 30 years of experience from Africa when COVID hit, and that colored my perspective on the pandemic a lot. I've been working on trying to eradicate measles with measles vaccine in Africa for many years now, and seeing that this is virtually, we are getting there, but it has taken 30 years with a vaccine that is super efficient against a virus that doesn't mutate and only has one host, namely the human being, and still how difficult it is to eradicate a virus with a vaccine. And so I was very aware that it would probably be very difficult to ever eradicate human coronavirus with a vaccine because we don't have as many good cards on our hands as so even with a very efficient vaccine, it would still be difficult to eradicate the virus. And so that I knew right from the beginning. I was also acutely aware, like everybody else, that this was a virus that was particularly harmful for the elderly and for people with multiple diseases. So very unlike the measles virus. I mean, had we had a pandemic with measles virus, it would have been devastating. But fortunately, it was a human coronavirus, which was only really dangerous in my interpretation right from the beginning if you were very old or very vulnerable, or if you got a very huge inoculum. And that we know also from Africa, from many other infectious diseases, that the higher the inoculum, the higher the virus dose you get, the more severe the disease. So it was dangerous. I'm not going to deny that it was a very dangerous situation where you have a new virus, even though it's a pretty harmless virus for most people. The mere fact that everybody was susceptible at the same time also in itself carried the risk of getting very severe disease because of the huge viral inoculum, and also because that could overwhelm hospitals. Even with quite mild diseases, there would be some who were so severely ill that hospitals could be overwhelmed, and that in itself would increase, as we saw, for instance, in Italy, the risk of dying from all causes. So I think a lot of these experiences from studying in Africa studying infectious diseases and vaccines in Africa for so many years made me think that the reasonable strategy forward was to find a way to coexist with human coronaviruses as quickly as possible, and in a way that at the same time cost as little as possible. And in my view, that was what led to the proposition that we should tame SARS coronavirus 2 to become a childhood disease, just like the other human coronaviruses, as quickly as possible. And that transition, there were papers also being published at that time that showing that transition towards becoming an endemic virus would happen quickest, and in a if the quicker children became infected and actually developed natural immunity. So that was yet another thing that colored my interpretation, that I knew that it would be highly unlikely that we wouldn't get some kind of natural immunity, at least towards severe disease, from getting infected, and we would build some kind of herd immunity eventually. And again, that transition towards endemicity and to that transition towards taming SARS coronavirus 2 would happen most quickly once the children got infected. That, on top of the fact that we would never, with a disease that is so mild in children, be able to show that the vaccine was actually a better choice for children than being affected, led me to propose that this should be a childhood disease. And that, of course, again, coming back to your research, it was additionally important that there were starting to come these safety signals saying that children could be severely harmed by the vaccines, even though it was only a very small group of children that would completely tip, in my point of view, the benefit-risk ratio of vaccinating.
So what you're saying is very controversial in the United States about allowing children to be infected. But I think we need to get back to the fact that in Denmark now, the Danish government has said, it was a mistake to vaccinate children. And so what you're saying here is actually really no longer controversial because, the Danish government basically said, well, because the risk to children is so low, the reason that we wanted to vaccinate children is to protect the adults. But all the children got infected anyway. So what we did not succeed. And so Søren Brostrøm said that, it was a mistake to vaccinate children. And in the United States, we have another situation where we continue to recommend that children receive boosters. And now
you have even made it part of the childhood
vaccination
which
program.
Is incredible
that's
to
right.
me, and would never. I don't want to swear on anything, but I find it so unlikely that would ever be policy in Denmark because it's simply not in any way justified based on the risk that children run and the potential harms,
and I think,
or the benefits they have from getting vaccinated versus the potential harms.
Right, and I think part of it has been getting a sense also in the US and worldwide of what the actual risk is to children, and we now know from the best studies that we have worldwide about the infection fatality rate in children that it was around 3 per million in children worldwide. And so, and I think that puts it into perspective how difficult it's been to show that the benefits of the vaccine would potentially outweigh, or that the benefits of the vaccine would potentially outweigh the risks when it takes a while to identify safety signals. I mean, we've seen how long it took with the myocarditis, and I know that you've been seeing some additional safety concerns in children and some side effects after the COVID-19 vaccine, and just how challenging that is to show that for healthy children that it was in their best interest that they get even one dose of vaccine. And even saying this, it's like I'm scared of it coming out of my mouth because I know how controversial what I'm saying is. But you're a vaccine researcher who's researched vaccines.
But listen,
for 30
Tracy,
years.
don't you discuss in the US that you would never dream of vaccinating, even if a vaccine, I hope not at least, even if a vaccine was developed against any of the other 4 human coronaviruses that we coexist with, that wouldn't be in any way cost efficient to introduce. We all get a cold once in a while, and it only becomes dangerous when you are very old and suffer from immunosenescence, and then you would basically die from whatever virus hits you at the bad moment, and that is the way life ends for many of us, and that's a natural end of life. So how comes that if we would not, no pharmaceutical company would contemplate making a vaccine for any of the other human coronaviruses? Why is it that you're introducing a vaccine against the 5th of them that we have now tamed to become a mild infection? And both it has mutated to become less severe, and also we have most people now having this herd immunity that makes sure that we don't get a high viral inoculum. So I think the mortality rates that you're quoting are even exaggerated compared with the current situation. So when we have something that is basically tamed to become a common cold, why is US then vaccinating against it?
And I wanted to get back to that point because those were the estimates from before children had natural immunity. And now, we can't even estimate what the infection fatality rate is in children. And another issue, of course, in the United States is the question about long COVID. And we've, of course, seen the challenges with the long COVID research. But the best studies that we have on long COVID, especially in young people, show it's incredibly rare. And now in terms of mortality rates, the study that we have from England, there was one that Shamez Ladani was involved in. They didn't have any children in England in their study that died after they'd already been infected the first time. So now we really are talking about a disease that is much more like a cold, whereas certainly someone could rightly say, well, the coronavirus was not like a cold in adults who had no natural immunity, certainly not. And this, and I don't think either of us want to make that point, and I want to make that clear. And you talked about before how you wanted to be able to live with the virus as it was, because we knew that it wasn't going away. And I think the world has come around to accepting that we're not going to achieve zero COVID. At least I think most people have accepted that. And so, but the one argument that people could make against what you're saying is that, well, we did get a vaccine that at least seems to temporarily provide some immunity to people who are very high risk. So were some mitigation strategies worth it in the beginning? And so that's, I think, a good topic of debate.
And I think it's important to say, because let's settle that. I think we are both happy that vaccines became available to the group of people that were highly susceptible to severe COVID-19, because there were no trivial mortality rates in the oldest part of the population. And again, from the also point of view that, I mean, in many old people, probably the vaccine would only change the course of death on their death certificate, but not have any profound effect on how many extra months or years of life they had. But they also came around and helped mitigate the whole pandemic course in the way that hospitals had better chances of coping with the extra challenge and burden of disease, etc. So I'm grateful that the vaccines were available. But again, I think when we have the situation where people have been naturally infected, we also know from almost all other pathogens that the second, third, fourth time you get infected, it will be milder. Mm-hmm. So it is a completely different epidemiological situation that we are facing now.
You are listening to Vaccine Curious.
And then we should also say that when we talk about, which mitigation strategies would we use, of course, something that I've been writing about is the fact that we didn't run randomized trials. And so what could we have done that would have actually worked, that would have postponed the time to people being infected? And
that's such a good question.
And I certainly don't think we have good evidence for masks. And school closures brings me back to the question of viral inoculum, and I'm just going to make a note about that. But the mask could potentially bring us back to that too. But we really and in terms of lockdowns, I think that people generally agree that if you're able to keep yourself away from all of other humans for an extended period of time, that you're less likely to get exposed to COVID-19, or you're less likely to get exposed to SARS-CoV-2. But then there's the question of the collateral damage, and we've certainly we see more and more studies showing that, especially for young people, that the harms of the lockdowns seem to exceed any potential benefits, and there haven't been really good studies that have shown that lockdowns in and of themselves have really been successful at protecting people, and that's because we are a society of people that needs to live. We need to live together. We depend on each other to get our food and to each other's company and for our happiness. So.
But you're absolutely right that there has been this terrible lack of randomized trials to test our interventions. And I'm so sad that we are now, more than 3 years into the pandemic, or since it started, and we don't have good answers to many of the questions that you are raising here. What was actually the effect of school closures, of masks, of vaccines, of lockdowns? And we could have been much wiser if we had implemented these different interventions in a randomized manner. But I don't know. I'm constantly asking myself, where are these barriers towards making or bringing in some kind of experimental design when we implement health interventions without really knowing their full effect?
That's a good question, and I do think people do not appreciate the power of how much knowledge you can gain from a randomized trial, and how you can substantially reduce bias. And I think people are also afraid. I think we touched on this earlier today when we were discussing that one of the arms of the intervention is going to be unethical. But when there is equipoise, which there certainly was about an intervention, then the most ethical thing is actually to do the randomized trial. And in Norway, they were actually planning on doing a randomized trial of school closures. But then they ended up reopening all the schools, and they didn't end up doing the trial. And of course, they never closed the schools again. And for the 6 weeks that they were closed, they say that was a mistake and that they harmed children unnecessarily. And certainly, compared to the 18 months of school closures that we had in California and some places, it was some even longer. But it's certainly we didn't generate the data to determine that found that it actually achieved its intended goal of keeping children safe, and we've seen so much evidence of harms now. Of course, educational harms, disproportionately impacting disadvantaged youth, and it's quite a tragedy in the United States. But I had a note that I wanted to get back to your point about the viral inoculum, because I think it's so interesting that hasn't been more discussed. And whether or not you could talk about just a little bit briefly about the research that you've done in other diseases and the concept of the more exposure that you get to a virus, the more severe your disease is, and sort of how you know that, and then how that maybe potentially could have explained the high infection fatality rate that we saw in Italy and in New York, where patients were hospitalized, near each other, or when people are at home in close contact with many people in their household rather than out at work and at school, for example.
Yeah. Yeah, so it's been seen in Africa for a number of different pathogens that if you're infected outside the home and you're a so-called index case, the one that brings the infection back into the home, then you usually get mild disease. Whereas if you're the person in the household that is exposed to the index case coming home, so for instance, the measles-infected child gets measles-infected in school, brings home the infection, is incubating the infection in its body for a number of days, maybe up to 14 days before the first index child actually becomes infected, then the siblings sleeping in the same room or in the same house at least, who are exposed to that first index case will develop much more severe disease. And in Africa, that brings about a more than fourfold difference in mortality among the index case versus secondary cases from measles, simply due to the fact that they are exposed more heavily or intensively to virus. And that has been shown in animal studies to lead to more severe disease. It simply shortens the incubation period also. So whereas the index case can maybe be up to 14 days before it develops disease, then the secondary cases get ill much quicker after they have been exposed to the virus, presumably overwhelming the immune system so that you cannot mount a proper immune response before you get really severely ill. So that has been shown for measles, it's been shown for varicella, it's been shown for pertussis, for a number of pathogens that you have that picture or that pattern. So I think that was a very important factor. And in fact, sometimes we achieved the opposite of what we wanted with the lockdowns, because we brought people home with their infections and locked them in together. And we very early on, based on the research done in Africa, we wrote an op-ed in Denmark writing, let the singles loose, let them out, and let them go about doing their normal business. They will go home and get ill in their own home, infecting nobody else but themselves. And that would be a way to achieve a gradual herd immunity.
Mm-hmm. And it's interesting that no real... I haven't seen a really good study into this with...
I've seen one animal
COVID-19
study, I think, with SARS coronavirus, too, where it also supports that issue, that aspect. That
wasn't the one where they put the little mask over the hamster, was it? I'm not sure, but it is. I think it was something that I was certainly very interested in the beginning of the pandemic, and I thought we would have good research on. And then we were just discussing whether or not, the fact that in Sweden the teachers had a lower risk of severe disease than their peers in other jobs. If that had to potentially do with them having like a small exposure when they were teaching, maybe never even testing positive. I did research into COVID-19 transmission as well, and was published with the CDC, and we in their journal MMWR, and we found a very low transmission rate in schools. Really, in the fall semester, out of 5,500 students and staff, there were only 7 cases that we found that were transmitted in the schools, and none to teachers. And a lingering question in my mind is, did some of them get it? Did they get antibodies and they just never had symptoms and they never tested positive?
I think it's likely, yeah.
I mean, because we certainly know that, a year into the pandemic, about at least a third of the people in the United States had already been infected. And we know that the asymptomatic infection rate is high. And so I do think that a lot of lines of evidence are sort of pointing towards that, school closures, they had many unintended consequences, and maybe even their effect against COVID-19 was counterproductive.
Yes, if it had been serving more or less like a vaccine to go into school and get a brief exposure and maybe just asymptomatic disease, yes. But we touched upon the fact that there were so few or almost no randomized controls trials being done, even though it had been, there are so many ways, and that's a whole podcast in itself, how many different epidemiological study designs that could have been applied to create these kind of natural experiments where you don't necessarily draw a lot that determines whether you wear a mask or not, but it could be different sub-regions in a country having different policies. You could introduce interventions in a step-wedged way where you kind of introduce it so gradually that you all the time ensure that you have comparable groups that receive the intervention and don't receive the intervention and so on. But regrettably, we can agree here at least that wasn't done, and we were left with the observational studies. And I would just like to ask you about that, because I know that you have been looking and scrutinizing the observational studies that have been published on some of these health interventions that have been claimed to be highly efficient, like the masks, for instance, and the school closures. And you have been. Well, can you tip us in on how you looked at these studies, and what are the problems with observational studies, and how have you seen the way these observational studies have been published and interpreted?
Yeah, absolutely. Because I think, I'll start with talking about vaccine data and a letter that we had published recently in the New England Journal of Medicine with Vinay Prasad and Ram Durasetti. So we basically we looked at a study that came out in the winter of 2021. I'm sorry, it came out in 2021. It came out in December of 2021. So the end of 2021 was published in the New England Journal of Medicine, looking at the mortality rate from COVID-19 after the first booster dose in adults 50 years and older in an Israeli population. And so they reported this adjusted 90% decreased mortality from COVID-19 among the boosted population. But this was a non-randomized study, and so what the authors did not report in the first publication was what were the differences in health. They tried to adjust for certain underlying health conditions, but they didn't adequately adjust for, at least we don't think so, in terms of what we were able to show in our letter. So they didn't adjust for the differences between the boosted and the unboosted population in the study. And what the authors ended up doing after they published their initial study in December of 2021, when they responded to a question about their study, they released the raw numbers of people in their study who had and hadn't received the booster of dying from non-COVID causes. And so basically, when I saw those numbers, I suddenly realized that we could get the non-COVID-19 mortality differences between the boosted and unboosted groups as a way. So some people call it a falsification endpoint, but as a way of seeing what the difference in health is between the two populations. And so what we ended up finding was the boosted population, and we'll call them the early versus the late boosted because that's technically what it was, but the early boosted population was had a 94.8% lower non-COVID mortality rate than the non-boosted population. And when you looked at their unadjusted data, the advantage that the boosted had against COVID-19 mortality was 94.6%. So it was almost exactly the same. I think that brought some attention to the potential biases and limits of using observational data. And certainly this healthy vaccine A bias, which is what it's called, is not limited to Israel. Now, I'm certainly not going to claim that it's always as extreme as a 20-fold difference in non-COVID mortality rates. But it points to the fact that, people who get vaccinated, and there are different reasons in different countries, but people who tend to get vaccinated earlier or the ones who get vaccinated versus not vaccinated are different than the people who may get vaccinated later or not at all. And so a randomized study would be able to eliminate that bias. And so we can talk about mask studies too. I want to make a note to remind myself that we can talk about other vaccines and what we can do in the future for evaluating vaccines. But we also I've also been involved in studies that have reanalyzed influential studies of mask mandates in children. And so one study was published by the CDC in their journal MMWR, and looked at the change in COVID-19 rates in the pediatric population after school started, but only looked at a 2-week period in the counties that did and didn't have mask mandates, and they found a significant difference between the schools that did and didn't have mask mandates. But we ended up extending the study out to 9 weeks, and that difference disappeared. There was no significant difference between the groups. And as a demonstration of if you sort of cherry pick your time frame when you look at the data, there are thousands of different ways to slice the data. And if you just happen to choose the right one, then you can find something significant. And if you move the date, just a week later or 2 weeks later, and it disappears, then you think, well, maybe the effect isn't real of what we found. And that's exactly what we did. And interestingly, MMWR did not publish our reanalysis, not citing any problems with our methodology, but basically saying that they felt like we needed more room to describe our findings. Well, we went on and had that published in the Journal of Infection, which has an impact factor of 38 the last time I looked. So it's a very good journal. And, publication bias is another important topic, but I'll just briefly say that the second study that we just released is a reanalysis of a masking study done by Høeg et al. In the New England Journal of Medicine, where they looked at a subset of school districts around the Boston region and looked at the 2 districts that ended up maintaining the mask mandates versus I believe it was 70-something districts that ended up dropping the mask mandates in sort of a staggered fashion 1 week apart from each other. And they ended up the way that they analyzed the data, they ended up finding that the districts that dropped the mask mandates had higher case counts. Well, we were able to show that if you expand it to the whole state, the difference disappears. It actually reverses, that there were higher cases in the schools that kept the mask mandates versus those that didn't. And if they hadn't used that specific statistical test that they used, which was a Callaway-Centena method of difference and differences, then when just using a simple differences and differences, and this is getting really technical, but then we also didn't find the statistical relationship. So all of this is to say that it's sort of very easy to slice and dice the data to get the finding that you want. And then there's this issue of the journals wanting to publish, having a motive to publish certain findings. And not only were they able to say, look at this intervention masking, which we've been arguing for all along. Oh, look, we now have more data that it works. And now we're going to add on to that a conclusion that masks are also effective, an effective mitigation strategy for systemic racism. And so then the New England Journal publishes this study, but certainly won't publish our reanalysis. And one has to ask, why do they want to publish one finding versus another?
Vaccine curious.
So that is what you have experienced when you have criticized, when your research and reanalysis of data and scrutiny of the analytical decisions made, when that has made it clear that a different conclusion had been reached or could have been reached, then you cannot publish you haven't been able, or it has been difficult to publish your
I think it's
rebuttals.
more difficult,
Yeah.
and I will say that the preprint server SSRN also rejected that most recent study, saying it was too sensitive of a topic, which is also concerning. But
it's very concerning, and it's so. I mean, we are scientists. This is so unscientific because you want to have your conclusions out there and your interpretation, your data, your raw data, your interpretations out there for scrutiny and for debate.
Yes, I want to get back to that raw data point because I think it's so important that, you know, every time that I'm involved in a study, we release the raw data on GitHub. And I just think that that is so crucial that you say when you release your findings and your data that you allow other researchers to go in and reinterpret and, you know, even identify if you've made any mistakes or there's flaws in the way you did your analysis. And I think every scientist should really have that approach because, you know, if you have done something that was incorrect, you want to know that. And I think that also protects researchers from accusations of having a fraudulent study. And I want to get back to the Clalit, the Israeli booster paper just for a second and say they have not made their raw data available. And I think that's very concerning that particular health system has had at least 6 very influential studies that were observational on the COVID-19 vaccine published in very high impact journals, and none of them have made the raw data available for reanalysis. And I think it should be, if we are not doing randomized studies, at the bare minimum, you really need to make your raw data available. And people have said, well, it's private health data. Well, there's certainly ways to anonymize it, so
or at least present some aggregated data.
Right, exactly. Yeah. So, but we should probably move on to talking about.
I think that's maybe. Yeah, let's talk about vaccines in general, and let's talk about the fact that, again, here we have situations where there are different interpretations of data, and that in particular we wanted to touch upon the fact that with the vaccination programs, Denmark and US have taken completely different approaches in designing vaccination programs, which is a clear indication that there is no universal truth out there. If there was unequivocal data showing that this vaccine schedule is the one that works, then obviously both Denmark and US would be using the same schedules. But we have made very different choices, very different interpretation of the available data, and that lack of or that presence of different interpretations is in fact also what you're talking about, what we talked about in the observational studies, that when a result is not very robust to any way you turn around the data, and it could be looked at from different angles and different conclusions have been reached, that's a scientifically very interesting and fruitful position to be in, because that means that we can become wiser.
Yes, exactly.
And this is also where we are with the vaccination programs, I guess, in a situation where we should discuss why have our two countries chosen such different strategies, and how do we get to is there one good strategy that none of the countries or one of the countries has achieved?
So I think, we should go over, and I completely agree with you that it shows that there is not consensus on this issue. There's not international consensus on the issue of exactly which vaccines children should receive. I mean, I will point out that there's a lot of overlap, but when I looked at the first 18 years of life, in Denmark, children receive 18 doses, and in the United States, it's at least 50. So that's a big difference. And when you look at the differences, which vaccines are different from country to country, so the two big ones that stand out are the yearly influenza vaccine, of course, adds a lot of doses to the U.S. childhood vaccination schedule. And so to make it clear to the listeners, Denmark and Sweden and I believe Norway, none of them recommend the influenza vaccine for people less than 65 years old.
I'm not sure about Norway and Sweden, but at least not in Denmark.
I know in Sweden it's also 65 because I looked that up recently. And then the COVID-19 vaccine, which we've been discussing. So the U.S. currently recommends that children at least have the primary series and a booster dose, and they did add it to the vaccination schedule. So as far as I know, they haven't announced that they want it to be yearly at this point. But I'm suspecting that that's the way that it's going. And of course, as we already discussed, this is based on not having really any sense of what the benefits of the vaccine are going to be. We only really know that it's not going to be risk-free. And so and then we can talk about the varicella vaccine. That's different. So Denmark does not recommend that children get the varicella vaccine, and I really want to get into that a little bit. And then the Hep B vaccine is also one that is not recommended in Denmark, and also hepatitis A is not recommended in Denmark. And I'm looking for my list here to see if I missed any that are
rotavirus
different.
vaccine.
Rotavirus, thank you. That was, and then I guess the meningococcal vaccine as well. That's the final difference.
Yeah. So that's a lot of vaccines that you've chosen to use in the US and that aren't used in Denmark. And I guess the overriding difference in principle or underlying principles is that in Denmark we have, until COVID-19 vaccines, only vaccinated against diseases that gave the individual child put it at risk of severe disease. So even socioeconomic considerations haven't played a role. For instance, rotavirus vaccine, I'm pretty sure that the Finnish have shown that it's cost beneficial. You save a lot of, it's not a severe, rotavirus disease is not a severe disease for children, but you save a lot of parents' days away from work if them and their children don't get rotavirus infection. So it's cost beneficial. It's not preventing severe disease in the child. The child would survive easily and happily with the rotavirus infection, but you simply save a lot of money even if you have to pay for the vaccines. But in Denmark, socioeconomic factors have traditionally not been allowed to play a role. So we only vaccinate against diseases that cause severe disease in the children.
And I think that's so important, because I think a lot of people who study medical ethics will sort of recognize that normally we don't accept that sort of consequentialist viewpoint of a medical treatment, that you will accept like harming a child to benefit like the economy or the adults. I mean, I guess we could think of counter examples to that potentially. I don't know. I'm trying to think of a counter example right now of a vaccine where I don't think that I mean, I think it's very good that Denmark prioritizes the well-being of the child, but that's a very interesting. It's an interesting point. So does Finland recommend giving the rotavirus vaccine?
Finland has an approach which is more like the US approach, where they also use the yearly influenza vaccine in children, and that's also they also introduced it. I have to say, the last 2 years we've used it in Denmark, and probably also this coming autumn. But that has been done entirely with the justification that this is not for the child. This is to prevent disease in the older population. So we are starting to deviate from that strategy of only vaccinating the children against severe diseases in Denmark too. But I also guess it's Denmark was affected by the pandemics episode in 2009 with the swine flu influenza vaccine that was used in many countries quite universally in the fear of a new pandemic with swine flu. And Finland, Norway, and Sweden also introduced it to children. But Denmark took a strategy based on these principles of only vaccinating children vulnerable children who had comorbidities, and we saw that there was this clustering of narcolepsia cases in the other Nordic countries, which was associated with the pandemics vaccine, but which didn't occur in Denmark, that didn't use the vaccine. So I think that has, consolidated, well, at least up to some extent, the idea that we don't use vaccines, that they come with a potential risk of harm. And that risk shouldn't be run unless there's a very good reason for it.
Yes, and I think we need to review for the listeners who might not know about the pandemics vaccine, that it was used for, like you said, the swine flu. I think it was 2008, 2009, 2008, 2009. And that there was this risk of narcolepsy that was actually from the adjuvant. It ended up being found out. So that's not necessarily going to be a risk for influenza vaccines moving forward. I was relieved to learn. But, you don't know when some risk like that is going to occur.
Exactly, as we couldn't have predicted the myocarditis risk that you'd then uncover from the COVID-19 vaccines.
Right.
And which is, in a situation where you have a mild disease like COVID-19 is a risk that you don't want to run because it completely tips the benefit-risk ratios towards harm.
And so, but Finland and Norway and Sweden now, like, they lived with that experience of, oh my gosh, we've given this many, I don't know how many children it ended up being that ended up getting narcolepsy,
several hundred.
But it was hundreds of children
with a severe disease.
It is a very severe disease, and the infection fatality rate, from influenza is in children in Scandinavia. The last time I looked is it's 1 to 3, 2 to 4 per million. So it is very low, and certainly high-risk children, I think, could be targeted, if
Absolutely,
they feel, for vaccines. And so that's the strategy that Denmark took, that they said the Pandemrix vaccine will be available for high-risk children. But I do think that that's an important point, that we need to remember that, it also took a while to detect that safety signal or for it to be acknowledged, even though apparently you could see it early on, and GlaxoSmithKline maybe didn't acknowledge that they were seeing it, which is also a scary thing. But I think that has definitely made, from what I've understood, it made Norway and Sweden and Finland, they held back more. They didn't end up recommending the COVID-19 vaccine to 5 for 11-year-olds who are not high risk.
Exactly.
Yeah. But
we are coming to an end, which is regrettable because we could have continued for a very long time. But we have to say, I think this is the first in a series of talks that you and I will do, also because when you tweeted about this, you asked people if they had questions to us. And I think we have only touched upon very few of the many questions that people posed. And I think there is I feel that there is a request for honest and transparent conversations around vaccines, and people don't feel they get it from the health authorities right now. And I think that is what you and I can actually provide, Tracy. I'm so happy we've started this conversation and that we'll be continuing it, because I think we come from the same place. We want to have good data, we want to have honesty and transparency around vaccines, and we both strongly believe that this is in the end how we create trust and become trustworthy.
Absolutely. No, this was such a good conversation. I want to say, we had planned to talk about the DTP vaccine and Hep B, and the
MMR
data for
autism
and MMR and autism and the varicella vaccine. So we just need to have we need to get together again soon and discuss that. But this was just basically an introduction to an ongoing discussion we're going to be having. So. Thanks so much for joining me, Christine.
Thanks so much for coming here, Tracy. And we'll leave it here, and just to say to be continued.
You've listened to Vaccine Curious with your host, Professor in Global Health from University of Southern Denmark, Christine Stabell Benn. Thanks for listening.